Thanks, Jeremy, and thanks, Lauren, for the invitation to present today. I'd actually, up until the middle of last week, kind of forgotten that it was in my diary, so struggled a little bit to think of something to present, and I'm hoping this is going to be useful to everyone. It does, I think, link quite well to last week's talk from Emily around childhood respiratory infections. And so what I'm going to be talking about for the next kind of 45 minutes or so is childhood pneumonia. And hopefully for many of you, this it will be useful to kind of contrast it with your experience in adults, or just kind of re-emphasize what you're currently doing for children. Just by way of overview, this is a talk I have given before, so some of you may have heard it in the last couple of weeks, or as you'll see kind of later on, possibly early in the year, because I gave a similar talk in Cape Town. But I'm going to start just with a very, very basic patient presentation, just to kind of set the scene for those of you who may not have worked with children all that recently, around kind of a fairly typical, straightforward childhood pneumonia presentation. I'm then going to play a video for you of the talk I gave earlier this year. It's a recording of that talk to the UCT Pediatric refresher course on childhood pneumonia. And then after that, hopefully quite a bit of time for discussion, because a lot of the aspects and some of the changes in the guidelines that we brought in kind of towards the middle of last year are somewhat, maybe not controversial, but certainly open to discussion, open to some interpretation. And I look forward to kind of that discussion with everyone. So to start, the patient that kind of highlights some of the issues that we're going to be touching on was patient ET. He's a 3.5-year-old little boy and presented to us probably a few weeks ago now with cough and fever for the past 3 days. His mom also noted that his appetite had dropped off recently. They reported no other constitutional symptoms. They had been to the pharmacy and received some over-the-counter medications from them, but they hadn't really improved his clinical condition. He's previously well, no previous significant medical or surgical history, and developmentally has been developing normally. As far as his mum knows, HIV, TB, or COVID exposures. And I'll come back to this kind of a little bit, we'll touch on it along the way. But the family are from Cameroon, but neither the mother nor the child have recently traveled there. His immunizations are up to date. So he presented to our emergency department just after 3:30 in the morning. At that point, he went through triage, and his respiratory rate was noted to be 32 per minute, which is tachycardic. His heart rate was 143, so tachycardic. He has pyrexia with a temperature of 38 degrees. And his SATs, measured on a few different occasions, kind of fluctuated in room air between 84 and 91%. And based on those parameters, he was triaged as yellow. He was given paracetamol and prednisone by the triage nurse. The paracetamol, I suppose, is reasonably easy to understand based on his pyrexia, but the prednisone, a little bit harder to understand. Shortly thereafter, he was seen by the ED doctor, whose notes confirmed cough, features in keeping with moderate respiratory distress, on auscultation, bilateral crackles. So they started him on oxygen, obtained intravascular access, and referred him to Ward 17, which is our pediatric admissions ward. In Ward 17, at just before 4:30 in the morning, so now just under an hour since he arrived at the hospital, he presented to the admissions ward. And interesting, and again, I'll touch on this a bit later, but on his way to admissions ward, there was time enough for them to be asked to, and for his mother to actually pay 385 Rand for the care he had received and would continue to receive. The vital signs on getting to the admission ward were largely similar. In addition, he had a blood sugar measurement, which was normal. He was examined by one of our interns just after 5 that morning, and that was followed by an examination by one of the pediatric registrars just before 7. So by this stage, he's been in the hospital for around about 3 hours. And their notes kind of record similar clinical findings in addition to what I've already mentioned. His anthropometry, so his growth was assessed as being normal. Their overall assessment was pneumonia. He had a full blood count, C-reactive protein and blood culture taken, was started on amoxicillin and clavulanate and paracetamol, and a chest X-ray was requested. Not too long after that, at around 8 o'clock in the morning, he was seen by a pediatric consultant on the post-intake ward round. And again, the clinical findings were largely the same as what the others had found. In addition to those, he was noted now to have some wheezing, but essentially really everything else was similar. And the decision at that point was taken against proceeding with the chest x-ray. He was then reviewed 3 more times over the following 24 hours or so, around about midday on the date of admission, about 2 hours later on that same afternoon, and then again at about 8 o'clock the following morning. And during those reassessments, he was weaned off his oxygen, his level of respiratory distress improved, he was discharged home on that second day on zinc for a 2-week period, paracetamol, and to complete a 5-day course of amoxicillin clavulanate. So a fairly typical, straightforward, relatively unremarkable short admission for pneumonia. The laboratory results, and it is important to note that these were obtained after discharge. So like many of you at the moment, we are having significant delays in obtaining results through our laboratory. And so I'm not sure if they weren't checked before we went home, or if they were checked and were not available. But regardless, the clinical decisions were made in their absence. But the full blood count came back as essentially normal. His blood culture remained negative, and his C-reactive protein was quite significantly elevated at 157. Also, because we are one of the NICD SARI sites, he did have a SARI sample collected, and the turnaround time on these is around about a week. So these results certainly weren't available at the time he went home, and we managed to find them kind of when I was putting the talk together. But his upper respiratory sample tested negative for COVID, for pertussis, for influenza, and for RSV. So my questions based on this sort of presentation, or questions that I think many people would kind of want to ask related to childhood pneumonia, include firstly, antibiotics. Should he have received them or not? And if yes, what should he have been given and for how long? Is a chest x-ray indicated in cases like this? And if so, what is the reason for it, or reason to do a chest x-ray? Should a TB workup have been done? Was it appropriate to have done viral studies? Yes or no? Was the zinc prescription appropriate? Did any blood investigations need to be done? And if the answer to that question is yes, which investigations? Was it appropriate for him to have received prednisone? And then, if we've got time, we can kind of touch on this. Should he have had to pay 385 Rand for his treatment? So now we're going to kind of transition to a recording of the talk that I mentioned that I gave in February this year to the UCT refresher course. And at the end of that, it will kind of come back for some discussion. So I'm hoping the video plays and the sound comes through. Please just let me know if any issues with that.
Good morning, everyone, and welcome to this talk on pneumonia in children, an update on the South African treatment guidelines. I'm Gary Reubenson, a pediatric infectious disease specialist at Wits University, working at Rahima Moosa Mother and Child Hospital. I'd like to express my thanks to the conference organizers and the Department of Pediatrics and Child Health at the University of Cape Town for inviting me to give this presentation. To start, I do need to declare a couple of potential conflicts of interest. Firstly, I am a member of the guideline writing group that was responsible for compiling these updated guidelines, and I also sit on a number of other committees that are in some or other way related to pediatric pneumonia recommendations. By way of an overview of the talk that I'm going to be giving, it is just going to be a brief overview of the full set of guidelines. If you are interested in a more comprehensive discussion of it, the South African Pediatric Association held a webinar last year where they covered the guidelines in a fair amount of detail. That presentation is available on YouTube at the link you can see on your screen at the moment. In addition, you can scan that QR code and it'll take you directly to the YouTube video. Importantly, we're not covering any COVID today. So a bit of a break from that. The guidelines themselves were published in 4 separate parts, looking firstly at the epidemiology and etiology, then diagnosis, management, and finally prevention. And each of those are freely accessible. If you are interested in the full text of those articles, again, the QR codes on the screen at the moment will take you directly to each of those publications. For our purposes today, I really am going to kind of just focus on each of those 4 components, but nowhere in as much detail either as the previous webinar or as the full text of those papers. To start with, looking at epidemiology, and particularly to start with, well, why are we still interested in childhood pneumonia? And this is part of the reason. If you look at the top 10 global causes of death from 2016, and there's no reason to think it's changed dramatically since then, lower respiratory tract infections were number 4 on that list. But when you start drilling down a little bit closer and look at lower and lower middle income countries, you can see that it moves up from 4th to 3rd. And if you look specifically at low income countries, you can see it remains top of the list of the conditions that causes death. And so while things have improved and there have been significant changes in epidemiology over the past few years, this remains an important condition, particularly for children. So what has changed over this time? So firstly, and I'm just showing you one slide here, there's lots more evidence to support this, but predominantly as a result of introduction of conjugate vaccines to children, there's been a substantial reduction in pneumonia worldwide wherever these vaccines have been used. In addition to that, a number of other factors, which I'll kind of touch on a bit later, have also reduced the burden of disease to some extent. Something else that's changed since the guidelines were first published is we have a lot more high-quality microbiological data available from children with community-acquired pneumonia. And these, to a large extent, come from multinational pneumonia etiology studies collected from children presenting with pneumonia around the world, some of which...
Sorry.
Universally non-susceptible to moxicillin, largely because conjugate vaccines. The Darkenstein study, microbiological data available from children with community-acquired pneumonia. And these, to a large extent, come from multinational pneumonia etiology studies collected from children presenting with pneumonia around the world, some of which have been highlighted on that slide you can see now, and certainly South Africa has contributed to those. And Cape Town themselves, particularly through the Darkenstein study, have also helped us better understand the viral and bacterial causes of pneumonia in children. So what specifically has changed over the last few years? Well, as I mentioned, related to introduction of conjugate vaccines, both Streptococcus pneumonia and Haemophilus influenza type B are substantially less important causes of pneumonia in children than they were in the past. But what's also been noticed, and this is an important point which we'll come back to again later when we're speaking to the recommended changes, recommended empiric therapy, which has changed from previous guidelines, is that while these conditions themselves have probably not substantially increased, both Staph aureus and non-typal Haemophilus influenzae now account for a relatively greater proportion of childhood pneumonia cases than they would have in the past. And as I said, largely because the other big causes, pneumococcus and Haemophilus influenza type B, are now less common. And one of the consequences of that is that you would therefore predict a decline in amoxicillin susceptibility amongst the isolates to causing bacterial pneumonia in children, both because Staph aureus is almost universally non-susceptible to amoxicillin, and Haemophilus influenzae, a substantial proportion, which will vary geographically, produce beta-lactamases, and so therefore also less likely to be amoxicillin susceptible. There have been increases in nosocomial pneumonia over the last number of years, and while this is an important condition, it's not one we're going to be covering in this talk today. there's been a substantial decline in HIV-associated pneumonia for a number of reasons. These include improved prevention of mother-to-child transmission, even when young babies and infants are HIV infected. Improvements in early infant diagnosis allow them to be identified earlier, initiate an antiretroviral therapy, and not progress to the same extent with respect to immune suppression than would have been the case in the past. What's also changed is that there's been greater recognition of the role that viruses play, and that tuberculosis quite commonly presents acutely, so as an acute pneumonia. Exactly what the relationships are between the viruses and bacteria remains somewhat of an area of interest, and again I'll come back to that point towards the end of this discussion. And also what we're learning about is that the kind of outdated idea that a single pathogen was predominantly responsible for disease in any one particular child's pneumonia is now accepted to be an oversimplification, in that in many situations more than one and often more than 2 or 3 potential pathogens can be identified depending on what diagnostics are used. And therefore trying to understand the relative roles each of those play. Are they significant isolates at all, or are they working together in some way to try and to essentially result in the clinical presentation is something else we need to keep in mind. Moving on from epidemiology to diagnosis. Something else that's changed in the last few years are the WHO criteria regarding what constitutes childhood pneumonia, and this is probably familiar to most of you, but is certainly part of the guidelines. And children presenting with cough and no other signs of pneumonia or severe pneumonia, starting at the bottom of this table here, would be labeled as having no pneumonia. Children who are either older than 2 months of age or have lower chest indrawing with tachypnea would be classified as having pneumonia, and the rest. So many of the patients, if not most of the patients that present to hospital are anyone below 2 months of age with cough and fast breathing, or any one of the danger signs, or hypoxia in room air, or signs of severe respiratory distress as defined by grunting or very severe indrawing, will all now be classified as having severe pneumonia. Moving on, and to consider the role of chest x-ray in the diagnosis of pneumonia, and an important understanding is that by and large, chest x-ray is not appropriate in most outpatients, or most children who are presenting with pneumonia who are not requiring hospital admission. It's not necessary, it's a clinical diagnosis, and in the absence of a need to investigate for tuberculosis or for other complications, it should not be routinely performed in outpatients, and therefore should be largely reserved for inpatients. And in my view, not necessarily even every single inpatient is likely to have benefit from chest x-ray being performed. Another question that commonly comes up is, when should follow-up chest x-rays be done? And the truth is, these are now considered to be seldom warranted. Times when you might want to consider performing a chest x-ray are to document resolution of a low-bar pneumonia, particularly if there's any concern about a foreign body as a predisposing factor in the causation of that low-bar pneumonia, around pneumonia, or in patients who are not improving as you would expect them to, or worsen while in hospital. Those would be reasonable indications to consider a chest x-ray. This is the table taken from one of those papers, from the paper on diagnosis, essentially summarizing what I've just said, where you would consider performing a chest x-ray in children admitted with severe pneumonia, suspected tuberculosis, suspected foreign body, if it's unresponsive to standard therapy, or and this doesn't directly relate to the child with presenting with cough and fast breathing, but certainly in some situations where children will present with a fever of unknown origin, and certainly a substantial proportion of those will have radiographic pneumonia, and the way to detect that would be with a chest x-ray. Moving on to consider the role of chest sonar. This is a modality whose use is slowly increasing. It remains fairly limited in its use in many settings. It has the advantage of avoiding radiation exposure. It's relatively cheap in that once the equipment has been purchased, each individual study doesn't add substantially to the cost. But it is very, very much operator dependent. You need to know how to use a sonar, you need to know how to interpret your findings, and there remains fairly substantial inter and intra-observer variability with respect to chest ultrasonography. But in support of sonar, there is an increasing evidence base, and the vast majority of that evidence base is that with a fair amount of initial training and some ongoing practice, it certainly seems to be an important modality that adds substantially to the care of children, and is something we probably should be trying to roll out more widely. Moving on to consider laboratory investigations. Firstly, HIV. And our recommendation is is that every single child that is presenting with HIV, whether outpatient, whether they're going to be treated as an inpatient or as an outpatient, should have HIV considered. If they haven't been recently tested for HIV, they should be offered testing, and the same would apply to their caregivers. Blood cultures, and certainly I'm speaking from a center where many, if not most, children being admitted with pneumonia do have a blood culture performed. This is something we probably need to revisit as to whether it's entirely appropriate, considering that most childhood pneumonias are not bacteremic, and so therefore the recommendation in the guideline is that routine blood cultures are not necessary and should probably be reserved for those who are most severely ill, being admitted to ICU, or where a nosocomial infection is suspected. What is the role of viral studies, particularly nasopharyngeal swabs, nasopharyngeal aspirates? And these remain somewhat controversial. They are an expensive investigation. Even when they are performed, how they're interpreted needs to be done quite cautiously. And what I'm getting at there is that, as I touched on in one of the earlier slides, is it's not unusual for 2, 3, 4, 5, 6 pathogens to be detectable in a particular patient, and so just detecting a pathogen does not necessarily imply that it's the cause of that child's condition. And this is borne out even more where you look at studies that have included control patients who are having upper respiratory viral sampling performed. And many of the things that we would consider potential pathogens are commonly identified in asymptomatic children. However, and I think this is an important point to bear in mind, that viral studies remain important for surveillance purposes, for things like understanding RSV circulation, understanding influenza circulation, informing vaccine composition with respect to influenza. So I'm not suggesting they have no role at all, but certainly in the day-to-day experience, my own view is that their role is fairly limited, and I don't think they should be routinely performed. What about inflammatory markers? And a wide variety of inflammatory markers have been looked at and continue to be looked at with respect to particularly differentiating bacterial from viral pneumonias. And unfortunately, we do need to continue looking for good biomarkers. Neither white cell count, neutrophils, ESR, CRP, or procalcitonin seem to be able to reliably differentiate bacterial from viral causes. They have some value in certain patients, but as a general rule, that value is fairly limited. This is the table related to first part of a table relating to the summary investigations in children with who are hospitalized for pneumonia, outlining advantages and disadvantages. I'm not going to go through each of these. You certainly have access to the presentation, but it's just really reaffirming what we're saying. In addition to what I've said, is pulse oximetry is a potentially useful thing to guide oxygen therapy. Chest X-ray has advantages but a number of disadvantages. Ultrasound has a number of advantages, but as yet insufficient clinicians have expertise in its use. Moving on to consider some blood investigations. Blood cultures are relatively easy to obtain, but the sensitivity is limited. Molecular testing on blood has no real role at this stage in the routine care of patients with community-acquired pneumonia. One exception to that might be, and I'll come back to this point a little bit later, around CMV pneumonitis. Serological investigations, certainly not routine, but maybe have some role with respect to certain pathogens. Biomarkers we've touched on already, and HIV we would strongly recommend testing in all children with pneumonia. Moving on to consider some other investigations. The first of those are the nasopharyngeal nasal swabs or aspirates, which we have spoken about. They're easy to collect, but colonization interferes with interpretation. They remain relatively expensive. However, certain pathogens, if detected, are more likely than some others to imply causality, and these include RSV, influenza, and tuberculosis. Sputa are relatively easy to collect, although they do require some expertise. They do have concerns around infection control and prevention aspects, but they certainly have a role in the diagnosis of some causes of acute pneumonia, including TB and pertussis. Urine antigen detection has no role really at this stage in the routine care of children with pneumonia. Finally, the role of more invasive forms of sample collection, tracheal aspiration, bronchoalveolar lavage, and percutaneous lung aspiration. Certainly the first of those may be relevant in the intubated child in the ICU setting, but they also have problems with their interpretation. They're commonly contaminated and certainly not routinely collected. And the role of percutaneous lung aspiration is really largely for at this stage for research purposes. Moving on to consider treatment, probably the most interesting and important aspect to many people who are listening to this talk. So firstly, coming back to the decision around, or just kind of give people an overview of in general what the approach would be, is children under 2 months of age are all considered to have severe pneumonia and so therefore warrant inpatient care. Children above 2 months of age, if they have no fast breathing, they can be managed at home with follow-up if symptoms worsen or they fail to resolve. But if children have fast breathing and or chest indrawing, that is sufficient, as you'll recall from the WHO criteria, to diagnose pneumonia. But in the absence of any danger signs or any signs of severe pneumonia or severe disease, they can be managed at home with oral amoxicillin initially, but close follow-up is recommended. Children who do meet the case definition for severe pneumonia, severe disease, should receive their first dose of antibiotic prior to referral and then be referred to a facility where they can receive ongoing care. At those facilities, so certainly, for example, our hospitals, we need to decide which of those children need to be admitted. Again, this is a table taken from the part 3 of the publication, outlining indications for hospital admission, and essentially pretty much saying what we already said, is all children under 2 months of age, those above 2 months of age who have any signs of severe disease or stridor or hypoxia or are malnourished should be admitted to hospital. And in addition to those that are HIV infected, immune compromised or malnourished with lower chest indrawing, so less severe signs of disease, should probably be best admitted. And obviously, it's not only the medical considerations, but if the child's home circumstances don't allow for appropriate care, it's entirely reasonable to admit a child like that. Moving on to consider antibiotic therapy. So firstly, the child under a month of age, and this essentially mirrors the general guidelines that many of you will be familiar with respect to treating late onset neonatal sepsis or suspected neonatal sepsis. And first-line therapy would be with ampicillin or penicillin with an aminoglycoside, usually gentamicin. In our setting at the moment and for potentially the foreseeable future, penicillin remains in short supply, and so by and large these sorts of patients will be given ampicillin and gentamicin. If they have a poor response, then a third generation cephalosporin is appropriate. And if cultures are negative and the child is improving clinically and taking well orally, we recommend a fairly rapid transition from parenteral to oral therapy, and in this setting to oral amoxicillin clavulanate, making up a total antibiotic duration of 5 days. If the cultures that are done are positive, then their results can obviously be used to inform susceptibility. Those results and their susceptibility pattern can be used to inform ongoing therapy, whether it's parenteral or oral. Moving on to consider the larger group of patients, those above 1 month of age. Or certainly above 2 months of age, we can reasonably consider outpatient therapy for them. And initially outpatient therapy, because most of those studies that I mentioned suggesting that Staph aureus and non-tubercle Haemophilus were performed in hospitalized patients. Our understanding of epidemiology for outpatients hasn't really changed all that much, and so therefore we continue to recommend amoxicillin. It's high-dose amoxicillin, so it will cover penicillin non-susceptible pneumococci in the lungs, but importantly, it can be given as a 12-hourly rather than as an 8-hourly dose. Total duration there is 5 days. If there is a poor response, then comoxicillin or amoxicillin clavulanate becomes reasonable. Again, high dose, 45 milligrams per kilogram per dose, but it can be dosed 12-hourly. Considering inpatients now, and initial therapy will be with amoxicillin clavulanate, and the idea being there we want to cover the common pathogens in addition to the ones that we're increasingly becoming aware of, so particularly here Staph aureus and some beta-lactamase producing Haemophilus isolates. The dose here is again high dose amoxicillin, and then transition to high dose amoxicillin. So what I'm getting at there is high dose amoxicillin as part of the amoxicillin clavulanate, and then transition to 12-hourly amoxicillin clavulanate orally. Again, if cultures allow for targeted therapy, that would be appropriate. Step down as soon as the child is clinically stable. For susceptible Staph aureus, our options would be flucloxacillin as first-line therapy there, and that requires a substantially longer duration of therapy. If there's a poor response to initial therapy, then with a third-generation cephalosporin, and in certain situations, you may want to consider broadening therapy to cover MRSA if that is an important cause of pathology at that particular site or in that particular area. Moving on to consider other therapies that might be considered. So first of all, in the setting of HIV infection or HIV exposure, particularly in the young infant, it is appropriate to consider pneumocystis pneumonia and CMV pneumonitis. There are slight variations around particular sites and clinicians' preference as to whether to initiate CMV treatment empirically while awaiting for results, or alternatively to send off samples, and if they're positive, then to initiate CMV treatment. My own approach in these patients, because I am quite concerned with how rapidly they can deteriorate, is to initially treat them quite aggressively, so with full PCP treatment and ganciclovir for CMV, and then as more results become available, potentially to narrow that therapy. What about oseltamivir? So essentially we see it as having a very limited, if any, role in the management of children with community-acquired pneumonia. Within the influenza season, it's not inappropriate to follow other guidelines, including the NICD guidelines, but it seems that it contributes fairly little to the care of children, certainly when used empirically, and even when used in confirmed cases. If it is going to be used, it needs to be initiated within a day or two of onset of symptoms. Corticosteroids can be considered when PCP is being treated and with some forms of TB, but is certainly not routinely recommended for children with other forms of community-acquired pneumonia. Vitamin A as part of treatment is not recommended. Vitamin D similarly as part of treatment is not recommended. In the more severely ill child, potentially in the ICU setting, blood transfusion should be withheld, and certainly in the hemodynamically stable child until the hemoglobin drops below about 5 to 7, much as it would for most other critically ill children. When considering fluid and electrolytes, we strongly recommend ongoing enteral feeds in the child who is able to tolerate that either orally or via nasogastric tube. In the more severely ill child who does require intravenous therapy, then we support using isotonic fluids rather than any other form of hypotonic fluid. Physiotherapy in general is not recommended. I'm not going to spend too much time on this. The guideline does go into a little bit more detail on the child potentially requiring ICU admission. It goes into some detail around who should be considered for admission to ICU, and then some aspects around how their care should be administered within the ICU setting. When can children be sent home? And these are largely intuitive: when they're improving, when they're active, they're feeding well, their fevers have settled, they're not hypoxic in room air, their baseline, they're back at their baseline mental status, and that therapy can be administered at home, and that home circumstances are acceptable, and caregivers know when the child can be brought back to hospital. Very briefly, just to consider prevention. Again, the paper goes into a fair amount of detail, but for our purposes today, just a couple of slides looking at tables from the paper. So firstly, considering general preventative strategies. So malnourished children are at high risk for severe pneumonia. So we want to try and reverse malnutrition, preferably prevent it, and certainly breastfeeding is protective in that regard. Routine vitamin A supplementation is important in reducing childhood pneumonia. Giving vitamin D to vitamin D deficient children seems to be beneficial. Similarly, zinc may have benefits with respect to reducing risk of pneumonia, and considering more broadly the childhood's home environment around reducing exposure to passive smoke, indoor fuel exposure, and appropriate infection control measures and physical distancing, including now around COVID, but also more broadly. Specific preventative strategies largely revolve around immunization. I'm not going to go through each of those. If there are questions, we can potentially take those in the question time. Antiretroviral therapy for HIV infected children has substantially reduced their risk of pneumonia and death. In the right setting, we must consider PCP, TB, CMV, and potentially in a small group of children, RSV preventative measures. Finally, and potentially this is maybe one of the more interesting parts of this discussion, well, where are there still areas of uncertainty? And I must say these are areas that I've identified, but I suspect there may be others that are of interest to some of you, and we can hopefully take those up a little bit later in the Q&A session. So what remaining questions are there? So what is the precise role of viral testing? I have touched on this a little bit earlier, and does the cost justify in my view, relatively small benefits? And as I've said, in my mind, this is not a particularly useful investigation in the vast majority of patients. Questions have been asked about the guideline group's decision to switch from recommending amoxicillin or ampicillin to amoxicillin clavulanates for empiric therapy for inpatients, and I've given you the reasons why the group decided to do that, largely because of the need for an increased spectrum of activity for the pathogens that are more likely to be involved. But we do need to understand that what's recommended here has not been well studied in this population, has not as yet in the modern setting been shown to be superior to amoxicillin or ampicillin, and does raise concerns around appropriate antimicrobial stewardship. And so while I think it is appropriate what has been recommended, I do accept that there are counter arguments particularly from a stewardship point of view. What about appropriate amoxicillin clavulanate formulations? So the guidelines recommend high-dose amoxicillin, and depending on the formulations that are available, it then becomes challenging to not give too much clavulanate which is responsible for many of the side effects from the medication. There are formulations that are available with appropriate ratios of amoxicillin to clavulanate, but they're not necessarily the ones we have access to in all of our hospital settings. This is an issue that has been recognized, and certainly the tenders that are out at the moment for provincial facilities specifically relate to hopefully companies tendering with formulations that have a higher ratio of amoxicillin to clavulanate. How do we deal with conflicting guidelines? So ours is one of but many guidelines, and there will inevitably be areas where they come into conflict with each other, and this is to some extent unavoidable. Certainly it's relevant to identify these conflicts, to try and understand where the different groups are coming from with respect to what they're recommending, and to become comfortable with what you're doing for your patients. No guideline is perfect. They remain recommendations that can be deviated from if there are good reasons, either because of the local setting or because of that individual patient. This is one I know we certainly struggle with at the bedside on an almost daily basis with respect to differentiating bronchiolitis from pneumonia. The guidelines make it sound very simple and straightforward, right, what bronchiolitis looks like compared to what pneumonia looks like, but many of our patients don't seem to fall exactly into one or other category. My own approach is that outside of typical cases of bronchiolitis, if there's any doubt and a child is more than mildly ill, so if they're hypoxic or requiring more aggressive forms of non-invasive ventilatory support, I would certainly err on the side of giving antibiotics to children that present with some sort of crossover syndrome or even predominantly features of bronchiolitis, but when they're more than just moderately ill. And then who to investigate for TB. So certainly within the guidelines, we recommend that everyone with severe pneumonia be investigated for TB, because somewhere in the region of 10% of those children we now know may well have active TB. But these are a huge group of children, and certainly investigating all of them does put some strain on resources, does have some infection control issues, and maybe something that individual institutions may need to talk about. But certainly the threshold for investigating for TB should be very, very low. So in the presence of any growth faltering, any malnutrition, any potential TB contacts, any failure to rapidly improve with standard therapy, we should absolutely have a low threshold for investigating for tuberculosis. That brings me close to the end of the talk. So firstly, or lastly, I'd just like to once again acknowledge the conference organizers and the clinicians at UCT for inviting me to give this talk, and also acknowledge all the other members of the writing group whose work I'm presenting here. And then finally, if the RT allows for it, we will happily take questions, and I'm interested to hear your thoughts on the guidelines, areas where you think we got it right, and potentially areas where you think we may not, and then may need to revise it in future editions. Thank you everyone for listening to the talk.
Okay, so that does bring us on to some time for discussion, and Gary, I'm not quite sure how best you want to do this. I can have a look at what's in the chat and take questions, or if you want to summarize and ask them.
Sure, Gary. Yeah, thanks very much. So yeah, if people do have questions, just type them into the Q&A box when you've got a moment. I'm going to start off with some of the ones that were sent to me, Gary, if that's okay.
Yeah, sure.
So one is about the use of steroids. So in adult medicine, there's at least some RCT evidence in favor of steroids, although I think on balance, most guidelines still don't recommend it for severe pneumonias in adults, although that would be the population potentially where you might. Is that it's clearly not the case in peds? Is that more because there is no evidence in that age group, or is that just, has the evidence to date just not found any benefit for severe pneumonia?
I suppose it's a combination of those, is that the available evidence is somewhat limited, but what is available doesn't support the use of steroids for treating community-acquired pneumonia in the absence of some other indication for the steroid.
Sure. And then Gail's asking, is there any role for physiotherapy in pediatric pneumonias, and why not? if not?
Because, and this is one of the areas where there is fairly good data, because the available data beyond some relatively small, poorly conducted studies where there was some benefit, but the vast majority of those studies that have looked at it have failed to find any benefits, and some have actually found potential for harm. So again, unless there's some other indication for physiotherapy, the vast majority of children should not be referred to physiotherapy with community-acquired pneumonia, and yeah, not just because it's unnecessary, but it may actually potentially be harmful. And again, I mean, I know we're oversimplifying there, saying that physiotherapy is kind of one entity, and we accept that that is a gross oversimplification, but where it has been looked at, it doesn't seem to have kind of reliably conferred benefits.
Okay, great, thanks. Cisa's asking, in patients with a viral pathogen identified on nasopharyngeal aspirate, would you stop the antibiotics without completing the 5 days? Or when does bacterial infection occur when it occurs? Is it early, concomitant, or later?
No, that's part of my reason for not for trying to discourage people from doing those tests, because if it was safe to stop antibiotics in a child with a pneumonia because there's a viral pathogen detected, then that would argue in favor of doing them. We don't have that evidence. We also know that simply detecting a virus doesn't tell you anything about whether there's a bacterial co-infection or whether that virus is actually the cause of that child's pneumonia. So yeah, so part of my reasoning for really discouraging the use of those tests is because they seldom inform the decision as to whether you can safely stop antibiotics or not. And even when people do them and find a potential pathogen, the likelihood is that most prescribers don't actually stop the antibiotics. So it really complicates the situation, adds to the total cost of the encounter without really giving information in the individual patient. Again, just to emphasize that I'm not talking about the use from a surveillance point of view, but for the individual patient, they kind of make things more difficult with respect to decision making rather than easier. One counter argument, and I think it is valid, is if you're able to get a fairly rapid turnaround time on your testing and your facility allows you to cohort patients, particularly with RSV, so that you can kind of keep all of them together and reduce the risk of nosocomial RSV transmission. I think that's the one argument that I've heard that I think does have some validity. But in our setting where the turnaround times are not fast enough and we don't really have kind of easy access to the infrastructure that would allow RSV infected kids to be cohorted together, it's not a compelling enough argument in my view for our setting.
Thanks. And this question, I think you've answered it, but they were asking about does detection of viral pathogens lead to any different infection prevention control measures? So you mentioned RSV. Are there any other viruses where it would change IPC practices or cohorting or anything?
Apart from COVID and RSV, no, I don't think so.
Okay.
No.
And then,
so I mean, sorry, just to kind of touch on that. I mean, many of the panels will include pertussis, and yes, that would have impact or would affect your kind of isolation IPC measures. But I mean, the question specifically mentioned viruses, so beyond COVID and RSV, I don't think so. But beyond what else you can get on the panel, yes, pertussis would also have that sort of implication.
Great, thanks. Vakil is asking a very difficult question about CMV pneumonitis and asking if there's any particular recommendation about a viral load threshold, or would you use tracheoaspirates or blood viral levels to decide?
Okay, so I mean, it is a very tough question and probably a talk in and of itself. The evidence that we have available is largely extrapolated from non-pneumonia CMV and even non-pediatric CMV. So you will see different people using slightly different thresholds. The one that's the most commonly found people using is a viral load in the blood of kind of above or below 5,000. Some people will use 1,000. I mean, again, I think as I mentioned in the talk, my own approach is in the right patients. So we were talking about the infant with severe community-acquired pneumonia requiring hospitalization, who is HIV exposed and of while you're waiting test results were known to be HIV infected, that they're the group at highest risk for CMV, and we see and for PCP, and we see that commonly those children present not looking all that sick, but not uncommonly will progress quite rapidly. So my own approach is to be aggressive to start with those kids, to give them treatment doses of cotrimoxazole, to give them ganciclovir, obviously to cover for the usual bacterial pathogens, and then as the HIV PCR result comes back, as the CMV result comes back, you can kind of fairly rapidly over the next few days kind of cut back on your therapy. The other alternative, which some people use, is to do the CMV viral load on the blood and to wait for the results and only to initiate treatment if that is substantially elevated. And I can't say that that's wrong. It's just I feel uncomfortable with that approach. Regarding the where to look for CMV, so the kind of more widely available option is on blood, because most of these children will not be intubated. For those that are intubated, tracheal aspirate CMV is less well studied, but as far as I'm aware, seems to have some utility in the right clinical setting. So if it's something that's appropriate for a particular child in that setting, I think it's reasonable. But for the vast majority, if you're kind of coming up with a guideline for childhood pneumonia for the country, it's not really something that we would be recommending.
Great, thanks. It's just such a tough question. We have the same problems in adult medicine. It seems almost eternally unanswerable in many ways. Ripka's asking an interesting question. She says, do you know if COVID-19 has affected the epidemiology of other childhood pneumonias in South Africa? Has there been a shift towards post-viral effects with bacteria, or any other epidemiology? I mean, I know that the epidemiology of things like RSV and some of the other viruses was profoundly affected by the lockdown. But I don't know, what do you think, Gary?
Yeah, so I mean, I think we're probably aware of the same data from SORI and from other surveillance programs, that it's a combination of factors. Obviously, less travel, both international and within the country, closing down of schools and creches and places where those viruses, I mean, not COVID so much, but the other respiratory viruses are largely transmitted, widespread use of masks, widespread use of physical distancing, all of those quite substantially impacted on influenza and RSV dynamics during 2020, and it looks like it's much the same, although maybe to a lesser extent in 2021. And so in 2020, we essentially had no influenza season. In 2021 to date, we've had almost no influenza isolates. We've had one in total at our hospital so far this year. And so it seems like those measures have were quite substantially impacted on the epidemiology of those viruses. Around RSV, we, to all intents and purposes, had no RSV in our typical season last year. We did see quite a few cases towards the end of the year, which was very unusual. And this year, we've seen quite a few, but based on the definition of the threshold that's in place to declare the onset of the RSV season. So officially there's been no RSV season, but it sounds a bit weird to say there's been no RSV season, but we've actually seen quite a number of cases. That's certainly less than what we would typically see. Our typical RSV season in Joburg is kind of late February to late May. And in that time frame, we didn't see anything like what we would normally see from an RSV point of view. But it is possible, like almost like what we saw November, December last year, when RSV started coming up when it was unexpected. We may well see the same this year around, that it's kind of out of phase for most years. With respect to, have we seen a difference in the pathology related to those viruses? No, not that I've been able to discern. No. When you see it, when they get it, it looks much the same as it normally would.
Yeah, it's absolutely fascinating, as you say, looking at those three examples of what the various measures did to COVID versus influenza versus RSV. And it, as you said, it's telling us a lot about the transmission dynamics, I think, in really fascinating ways. I mean, I know that in other countries have seen also this out-of-season rise in the RSV, I think, as their various, lockdown and associated measures were changed as well. I think the US has had a big summer peak now, if I'm not mistaken. Gary, the last couple of minutes, just two last quick questions, if you don't mind. One was asking about how quickly would you expect a response to empiric antibiotics in bacterial pneumonia, and just with the kind of the writer being that this person has seen quite a few children escalated quite quickly to second-line antibiotics because they have, quote, failed to respond. So when would worry you about a failure to respond to appropriate antibiotics?
It's somewhat difficult to answer because the reality is the vast majority of those pneumonias, we don't actually find the bacteria causing it. So to be able to say that this is a bacterial pneumonia that has failed to respond to treatment isn't the typical situation. The typical situation is we have a child with an undifferentiated pneumonia that fails to respond to treatment. The majority of them would certainly be improving within about 48 to 72 hours. And it would be unusual for them not to at least start to improve in that sort of time frame. So yeah, and from our point of view, kind of if they're getting worse or haven't at least started to improve after a few days, we'd be looking at reasons why that's the case, and part of the response that may well be escalating or broadening therapy.
Okay, and then two questions which really can be done together about PJP. One is about if you empirically started on a patient who has HIV. At what point are you happy to de-escalate? In other words, or do you empirically start it? And then the related question is about if it's confirmed PJP, when would you start ARVs in a child?
Okay, so on the first question, I mean, we do empirically, and it's certainly a very small group of patients these days. So before it used to be lots and lots of them. So in the HIV unexposed child, we're for fairly obvious reasons, unless there has some other reason to expect congenital immune deficiency, we wouldn't be considering empiric PCP treatment or pneumocystis treatment in them. In the HIV infected infants, so we're talking under a year of age, we would certainly consider, and most of us would start treatment doses of cotrimoxazole on them. And in the HIV exposed, uninfected, but where there's still kind of some possibility of some possible ongoing risk of infection. So in the breastfeeding mom who's not virally suppressed, or where you kind of haven't yet got to a 10-week PCR or something like that, that sort of patient, we would have a very low threshold for treating with treatment doses of cotrimoxazole. With respect to when we would kind of de-escalate, it's largely based on the clinical response and as the rest of the results come back. So I think many of the people in the audience are aware that PCP can occur in the HIV-exposed uninfected infant, but it's actually quite uncommon. So it does exist, and certainly if the clinical picture makes you concerned about that, then it's reasonable to continue treatment. But most patients, by the time the HIV PCR test comes back 24, 48 hours after admission, and they've started to clinically improve, we would typically stop the pneumocystis treatment at that point. And in the HIV infected infant, it's kind of that small group where we confirm it, we continue, and even when it's not confirmed, much of the time they'll kind of complete the course of therapy.
Okay.
And so the second half of the question was around
timing of ARVs.
Oh, okay, yeah. So usually we would initiate ARVs if they aren't on it already prior to them kind of going home from hospital. So within a few days, and certainly once they're kind of clinically stable, we'd fairly rapidly initiate ARVs.
Okay, great. Thank you very much, Gary. That's a masterclass you've given us, and lots of questions, as you can tell, which is always a great sign. Thank you very much for your time. Greatly appreciate it.
I have a couple more slides. But,
sorry.
No, it's fine. Pretty quick. I mean, it's kind of we touched most of them before.
No problem.
Just coming kind of back to the questions that I posed, and they were exactly the same ones initially, and kind of proposing some answers. So, and I think we've dealt with all of this. So yes, I think antibiotics in a situation that I described would be appropriate. And I think you can make arguments either in favor of moxicillin or moxicillin clavulanic. Chest X-ray probably indicated the TB workup. I think you can make arguments in both directions. We chose not to do one, but I think it wouldn't have been inappropriate to have done one. The viral studies, I'm arguing, didn't need to be done. Zinc didn't need to be prescribed. The blood investigations, I'm saying a yes. They were really only HIV. The other investigations that were done, and I think you saw quite well, the results weren't even available at the time of discharge, and so it clearly made no difference to the child's management. the pregnancy in this child situation, I don't know, and we don't really have time today. But we are kind of dealing with a situation where we are pregnant women and children under 6 years of age should not be expected to pay, but recently over the last few weeks and months, they are being expected to pay, and we kind of fighting that from an advocacy point of view. And I don't think it's appropriate for this mother to have been asked to pay that money. I think that's the end. We'll leave it there.